Luther again. We're going to go through the third segment of our part 1 of endocrine conditions where we talk about thyroid nodules. So a thyroid nodule is any discrete lesion within the thyroid gland, and they're going to look different from the surrounding tissues when we look at them on radiologic testing, such as an ultrasound or even a CT scan of the neck. These nodules are incredibly common, and so even in the US, where we don't have much iodine deficiency, almost 68% of the population has thyroid nodules at any given time. Not all of these are palpable, and many of them are never going to be found, or they may be found incidentally on imaging or exam for other things. So you absolutely will encounter some thyroid nodules in your practice. Over 16 million Americans have them. Again, about 5% of the population will have palpable nodules, and but 219 million have radiologically identifiable nodules. So these nodules can either be single, we call these solitary, or they can be multiple. Women, older adults, and people with higher BMIs are more likely to have a goiter that is multinodular. So there are 3 categories of problems that thyroid nodules can create, but most thyroid nodules, about 95% of them, will be totally asymptomatic. We consider a thyroid nodule clinically relevant if it is malignant, so cancerous, if it grows to a size that it starts to compress the other structures in the neck, for example, blood vessels, the airway, or the esophagus, or if it's producing or preventing production of normal thyroid hormone. So of all the nodules that are identified in practice, only about 10% are malignant or pre-malignant, and risk factors for malignancy of thyroid nodules include a history of irradiation or exposure to ionizing radiation in childhood, or if the patient has a family history of thyroid cancer or cancer syndromes. If the nodules are growing more rapidly, they're more likely to be malignant, or if there's associated hoarseness. We don't recommend, at least the USPSTF does not recommend that we screen asymptomatic patients without risk factors for thyroid disease, thyroid nodules. And we screen patients who do have risk factors, patients with risk factors are not seen to have better morbidity or mortality outcomes when we screen them with ultrasound. So we really don't screen very often. The only kind of aside to that is that if a patient has a first-degree relative or that has a known hereditary medullary thyroid cancer, we can offer that to screen them with ultrasound. Sorry, too far. Okay, so symptoms of thyroid nodules. Most of them are asymptomatic, but they can cause constrictive symptoms, and these are typically a globus sensation or a feeling that something is stuck in the throat. This normally doesn't occur until the mass is larger than 3 centimeters in diameter, and it has to be located near the trachea. So it's usually located on the isthmus, which, if you can see, is the center area of the thyroid that touches across. Swallowing complaints are the most common cause of thyroid nodule complaints, but they can also be present when the patient just has hypothyroidism without nodules. And the swallowing complaints typically occur if the nodules are in the left lobe and extend posteriorly, because this means that it's going to compress the esophagus and the neck. Hoarseness has been linked to an increased risk of malignancy, and pain is normally due to a sudden increase in nodular size, such as when the nodule ruptures and bleeds. So what do we do with thyroid nodules? As the provider, the very first thing you're going to do, as always, is a thorough history and physical. So your history is going to be looking for those neck symptoms or compressive symptoms, such as difficulty with pain, breathing, or swallowing. The next thing you're going to look for is the symptoms of hypo or hyperthyroidism. Your physical exam is going to include qualities of the nodule, such as texture, borders, and changes in size and the size itself. You're going to look for generalized enlargement of the thyroid in addition to the nodules, and you're going to look for those signs and symptoms of hypo or hyperthyroidism that we talked about before. You can see here on the right, there's an outline of the process of evaluating thyroid nodules, and we're going to get into this in a little bit, but for every patient, regardless of the TSH, we need to get a thorough history and physical exam. So Our primary goal when we're dealing with thyroid nodules is the first thing we're going to do is make sure that it's not a functional nodule. So the very first test that we're going to do is one called serum thyrotropin. The serum thyrotropin helps to tell us whether the nodule is making functional thyroid hormone. If it is producing either T4 or T3 independently, then the hypothalamus will stop stimulating the thyroid by reducing its production of thyrotropin. So if the serum thyrotropin is low, you're looking for a nodule that is producing hormone. This will lead you to do a radionucleotide uptake scan, which looks for focal metabolic hyperactivity of a nodule. If the serum thyrotropin is high, you're looking for a Hashimoto's autoimmune thyroiditis. It suggests that there is not enough functioning thyroid tissue because of displacement of the functional thyroid tissue. So if the value is normal, that is actually a good sign. So the first thing we're looking at is whether or not this nodule is either producing hormone or preventing the thyroid from producing hormone. We do not recommend serum thyroglobulin testing or calcitonin testing. These were used in the past for thyroid nodule screening to determine if the nodule was likely to be a thyroid cancer, but neither of those tests has been helpful in reducing morbidity or mortality. So the evidence does not support those tests, so we don't do them anymore. If you have an abnormal serum thyrotropin level or your thyroid hormone levels are not normal, you want to send the patient to endocrinology. So now that we know that our patient does not have a functional nodule, the next step is going to be an ultrasound. So the ultrasound is looking for non-functional nodules, whether or not they are thyroid cancer. So this is going to be done whenever a thyroid is palpably abnormal or if a nodule is found by accident when we do other imaging. And this can help to differentiate an inflammatory goiter from a superimposed nodule. So it'll tell you if the tissue of the thyroid is just all in all inflamed or if there's a nodule that's actually causing an enlargement on palpation. And then this also can help to look at the background tissue of the thyroid around the nodule, can give some characteristics as far as the location, the size in a 3D plane. So give us all three directions of the size. It can give you some sonographic features. So whether it looks very dull or if it looks very enhancing, and it can also identify the presence of cervical lymph nodes. So you're going to, many patients are going to be referred to endocrinology before the thyroid ultrasound is ordered. However, this is not necessary. You absolutely can order a thyroid ultrasound for a patient. And so sometimes the patient wait time to get into endocrinology can be really long. And so it can be helpful if you order the ultrasound in the meantime so that it's already done by the time they get to the endocrinologist's office. And the endocrinologist will really thank you for taking the initiative to do the testing. And so the ultrasound is going to give you a score, and the score is going to be the TRAD score. So among different imaging tests, there will be things like the BIRADS, the TIRADS, and those are thyroid imaging reporting and data systems. The BIRADS is the breast imaging reporting and data systems. So you'll see those. You can get a good clue as to what you're looking at based on that first letter, the T, in the IRAD system. So the American College of Radiologists TIRAD system scales nodules in terms of 5 feature categories that are summed up to determine a risk level that is between TR1 and TR5. And then the recommendations for whether or not a lesion should be biopsied or if it should be followed with ultrasounds for extended periods of time are based on that score, as well as the maximum diameter of the nodule. So certain characteristics that increase the risk of thyroid cancer include solid composition of the nodule, hypoechogenicity of the nodule, irregular margins, the presence of microcalcifications, or interrupted rim calcifications. If it's a pure cyst or nodule with a spongiform consistency, then it has a very low risk of malignancy, which is less than 2%. Nodules that are solid but are not calcified and have smooth margins have still a pretty low risk of cancer of about 5 to 10%. So we kind of follow those a little bit, but we're a little bit more conservative about it. So step 3, any nodule that is suspicious enough based on that TIRAD system will be recommended to have a fine needle aspiration. And this is actually something that will show up on the ultrasound will say that the TIRAD score is blank and fine needle aspiration is recommended or something similar to that. So the fine needle aspiration is a biopsy that can provide definitive cytological diagnosis, and they usually do it under ultrasound guidance. The results will be reported with a classification system called the 2017 Bethesda classification system, and this is used for clinical decision making. So you can see here on the right an example of what that looks like. I will tell you that unfortunately about 20 to 30% of fine needle aspiration biopsies come back as indeterminate. And so these will require additional testing. So these rarely represent true cancers, but it is possible. So we usually avoid surgery in patients who have indeterminate biopsies, but we follow them with watchful waiting and make sure that they don't progress into anything that's concerning. If there's a pure cyst on the ultrasound, then it's not recommended that we do a fine needle aspiration. And if it's a spongiform nodule, we will only do it if it's greater than 2 centimeters at maximum diameter. So finally, once you get your FNA or, during this process, if the patient is diagnosed with a lesion that is recommended for removal, whether it is a malignancy, pre-malignancy, or suspicious enough or large enough that surgery is going to be recommended, we need to get that patient to the right person. So if the patient's going to need molecular testing to look more deeply at the type of tissue that's involved, we're going to send the patient to endocrinology. If the patient has compressive symptoms, or if the nodule looks malignant, we're going to get them to a surgeon who has experience with thoracic surgery, or a general surgeon with head and neck experience. If the Bethesda score comes back as less than 3, we're going to do repeat biopsy fine needle aspirations as indicated based on that scoring system. And then if the patient requires additional imaging, such as a CT or MRI, which might be used when the tumor is large or recurrent, or if there are unexpected extrathyroidal extension of the tumor. So if we think that the tumor has moved beyond just the thyroid, or if we think it's metastasized to different distant locations, or if there's regional lymph node involvement. So if there's some reason that this nodule is more complicated than just a nodule, we might send this patient for more imaging, and that's typically a CT or an MRI. So thyroid cancer is not very common, but it is the most common endocrine cancer. So about 0.4% of the population will have some form of thyroid cancer throughout their lifetime. Risk factors include an iodine deficiency, female gender, family history of thyroid cancer, or exposure to ionizing radiations. There are a couple of different classes or classifications for thyroid cancer. There's differentiated, which is either papillary or follicular. And there's undifferentiated, which is medullary or anaplastic. Medullary thyroid cancer is more likely to be familial, and we're going to talk about a syndrome called multiple endocrine neoplasia in our second part of our endocrine lecture, and that's one of those familial syndromes that involves medullary thyroid cancer. Anaplastic tumors are the fastest growing of all thyroid neoplasms, and they have a very high mortality rate. So these undifferentiated ones are the ones we worry about the most, and they need to be gotten into treatment right away. And then the other types of cancer, especially the differentiated kind, tend to be a little bit less aggressive, slow growing. And so we still are pretty, we want to get them out, but we feel a little bit better about prognosis when the tumors are more differentiated. So the diagnosis is made on biopsy, and individuals who are either under the age of 20 or over the age of 60 with a new thyroid nodule are at the highest risk for that nodule to be malignant. But regardless of the type of thyroid cancer, prognosis is usually pretty good. especially when the tumors are found early or when the nodule is less than 2 centimeters. And if the histology is favorable, so one of those differentiated types, or if it's localized, so the less spread, the better. Thyroid cancer treatment is going to typically involve surgical resection of one or both lobes of the thyroid. You can also do radioactive iodine, which can be used to ablate any remaining thyroid tissue. And then additional treatments are going to depend on the type of malignancy that makes up the thyroid cancer. Patients who are post-thyroidectomy or post-ablation are going to require lifelong thyroid replacement therapy. So their goal is to keep that TSH above 0.1, but you want to be in the therapeutic range, so that 0.1 to 5 range, thereabout. Patients should be taught to do a monthly self-neck check, and providers really should continue to observe that patient for the first 3 to 4 years. So as the primary care, you need to just know which patients are affected and make sure that they're getting the follow-up that they need and deserve. So that summarizes the end of our thyroid set of endocrine conditions. There is a part 2 where we're going to go through conditions a little bit more quickly. It's not quite so focused on one gland like the thyroid. So we're going to go through some of the issues that affect the adrenals, the parathyroid, some metabolic conditions, etc. So please follow on the next presentation. And if you have any other questions, please post them to that 24/7 office hours discussion board. Thanks so much.